All right, I'm going to go ahead and call to order the October 6th Public Safety Meeting. Thanks for being here today. We're going to go through discussion items and then public testimony afterwards so that everyone has the opportunity to hear all the updates before testifying. So we'll start with the opioid treatment presentation with Bob Lutz first. Thanks for being here.
Council President, Council members, Bob Lutz and Kayla Cross.
Morning.
So I am going to be starting off with primarily just the epidemiology, and then Kayla will take it from there. So as you've heard over the past year or two, we're seeing sort of a national decline in overdoses. I wish we could say that national decline is universal and uniform across the country. It's not. Primarily seen in the Northeast, Southeast, and Midwest, but unfortunately the Western states continue to see upticks. This is Spokane County. These are counts. Okay, and so just again, I'm not going to look at the numbers, but just note that the trend is in an upward direction, albeit maybe there was a big spike in January, February. If I drop that down, I think we could maybe see a little bit of a plateauing and a trending towards a plateau, but right now we're certainly not seeing a decrease. So that's all drugs and opioids. This is synthetic opioids, i.e. fentanyl primarily. Again, that spike noted in January, February. Psychostimulants, i.e. primarily methamphetamine. Do note that cocaine is on the increase as well. And then polysubstance. Again, the majority of individuals who overdose are polysubstance. These are rates, and so these are adjusted rates, and these are adjusted rates for age. 2024 being preliminary data, but again, you can see the green line is Spokane. Spokane is higher than the eastern portion of the state, as well as Washington State as a whole, which is seeing a little bit of a plateauing and or overall decrease. Again, opioid involved, synthetics, psychostimulants, and then again, just to talk about a little bit briefly about where the overdoses are occurring. This is the medical examiner's data from last year, and you can see that a slightly increased number of individuals who are housed versus unhoused. But again, overall, 300 plus deaths last year from overdoses. And then what Kayla's going to talk about, this is what's called a continuum of care. It came out from the National Association of Governors, and it looks at, if you will, treatment and working with individuals who use substances from the prevention, harm reduction, treatment, recovery continuum. So, any questions for me while I'm up here about numbers? Yes, sir.
Just quickly, on the polysubstance, are there any like 2 or 3 or however many that are most combined in those overdose numbers?
Yes, sir. It's primarily going to be fentanyl and the psychostimulant methamphetamine.
Okay, thank you.
Yeah. I just want to make one other comment, if I may. There was recently a video that I saw where there was a report or a statement that Spokane has the second highest rate in the country of overdoses, and honestly, I don't know where those data are coming from. We see the data from the CDC, we see the data from DOH at the county level. There is no uniform way to look at municipalities. I talked with colleagues at DOH, they were kind of questioning that data point or that statement. I also went to the Metropolitan Service Area website and could find nothing related to overdoses. So just note that there are actually there are counties across the country that have overdose rates in the 200 range. Washington State right now much less, and Spokane County looking at maybe for 2024, maybe a adjusted rate of about 54. So that's a far cry from counties in West Virginia and Kentucky that have rates in the 200 range per 100,000.
Could I, sorry, real quick, Dr. Lutz, can I see the housed and unhoused numbers one more time?
So housed in yellow, 197, unhoused, 136, and that's from the medical examiner's report last year.
Thank you very much.
Yes, sir.
Hello, I'm Kayla Cross. So just going to briefly talk a little bit about kind of the continuum of care with substance use disorders. So there is of course, a continuum. So people start substance use at different points in their lives. Most people start before the age of 18. So we really want to make sure we're focusing a lot of efforts on prevention, early prevention with our adolescent population in our schools, making sure they know about safety, know about naloxone. And then there's this continuum of care, and it's not linear, right? Like recovery is not linear, life is not linear. So sometimes there's different bits and pieces of this process that are going to be the best place to connect with different people along their recovery trajectory. So in this slide, we just have primary, secondary, and tertiary as far as kind of where in the realm of care people will fall. And some of that's more towards prevention, and then some is more towards harm reduction and treatment and more intervention. Okay. So as far as prevention goes, we want to intervene early. We want to provide that information to people. We want our adolescents, we want general population to know there is treatment available, evidence-based treatment that works, especially for opioid use disorder. Those medications that we talked about last month really are the gold standard for treating opioid use disorder and substantially reducing the amount of deaths, overdoses, negative effects of ongoing substance use. We really want to work on reducing risk factors for people that are maybe more higher risk to be using substances later in life, emphasize their protective factors, and then of course be culturally considerate about what's going on in their environment, culture, situation, and be addressing some of those things that we know make people at a higher risk for developing substance use issues, mental health issues, homelessness, all a range of problems that can negatively impact them later in life. As far as harm reduction goes, really this is focusing on promoting safety, just kind of across the board. We know harm reduction works, right? We use it with seat belts, we use it with filters for cigarettes, we use it with like prophylactically giving antibiotics sometimes to make sure people don't end up with an infection if there's a high rate of infections with things. So some of that is identifying any kind of drug use early, again, to provide treatment early on before it becomes a very big problem, education, improving safety, and promoting access to treatment and services. And we talked last month a little bit about making sure that access is available to everybody. So right now, and this is something our entire country kind of struggles with, but you know, insurance varies on how it covers different treatment options. Medication availability varies as far as, are you rural, are you local, do you have transportation, are you able to jump through sometimes the barriers or hoops required to engage in treatment, can you show up to your appointments consistently, get your meds filled, that type of thing. So we really want to make sure we're being considerate of making sure we address those barriers so that people that need the treatment can access it and then can stay engaged in it. This is just a little bit more on harm reduction. So the ones kind of above are, you know, how we apply harm reduction and promoting safety in other arenas. And with substance use, especially here in the States, there's a little bit more maybe political, you know, controversy or whatever behind it, but we know it works. It works in other countries, it works here. There's been lots of research and studies done on providing harm reduction interventions. So that is like safe syringe disposal, clean syringes, naloxone, naloxone access and education, the medication-assisted treatment for treating opiate use disorder or other substance use disorders. Housing first models really have really good success rates, and then getting people connected with services that they need. And that is not necessarily just for substance use, but across the whole continuum of various risk factors they might have or challenges that they might have. And then further part of that treatment is having treatments be evidence-based, and we'll talk a little bit more about that. Meeting people where they're at, so figuring out individual goals. Sometimes that means they only want to work on one thing at a time, and a lot of times, like, that's fine. We just start where they're ready to start, and then hopefully just kind of keep building on gains that they have. We want to kind of have an ongoing care progression with people, so kind of like primary care where you continue to see people over time and it's not just kind of a one and done, and then if they don't follow up within the parameters of what the clinic requires, then they're, kicked out of the program or something. No, we want to continue to see them, continue to kind of look at that risk over time, try to mitigate the risks, prevent any potential safety issues that we see could be happening, and keep them connected with services and hopefully help them be a lot more productive and functional. And then we always want to have options, right? Because it's great to be able to provide people with options to what they want to engage in and have like available services that are desirable and interesting to them that they want to engage in and don't feel like a burden or are too challenging to meet requirements of. So we know there's lots of kind of treatment recommendations and lots of people have opinions about what treatment should be offered and what works and what doesn't work. But we do know a couple things because there's been evidence, there's been research done on different treatment approaches. So we know that involuntary, coerced, or required treatment is not supported by research. It actually increases the risk of overdose at discharge once people are released because you can't keep someone in required treatment forever, right? So once they're released and kind of into this forced abstinence, there's a significantly higher risk of overdose and death at release. Most of the time, required or involuntary treatment does not. Well, you can't compel, you can't require someone to take medication for a substance use disorder. That is not a process that we have available. So if someone decides, they want to engage in medication, that is a different story. But if it is required medication, we cannot force people to take medication for opiate use disorder or other substance use disorders. Even with like our Ricky's Law, we can require people go to treatment, like they can be evaluated, and as long as they're not having withdrawal symptoms that have to be managed in like a hospital, we can require them to go, but it's a very short window that they can be required to be in one of those treatment centers, and that those treatment centers cannot require them to take medications for the substance use disorder. So then they are, getting whatever kind of substance out of their system and then discharged generally back into the same situation that kind of helped present them into that being detained situation, often relapse or use again, and then very often overdose or have death or other negative consequences associated with that. There's also inpatient or residential treatment. Sometimes that's a week, 2 weeks, 30 days, 90 days, depends on the program. There's lots of different programs out there and available. These can be very beneficial because people can learn new skills, kind of get some sober time under their belt, learn about stress management, healthier coping skills. But if they're not also paired with some kind of medication, the evidence shows, right? Evidence-based, most successful treatment is the medication for opiate use disorder. A lot of times, again, people will discharge, come home, struggle to connect with services, sometimes resume use, overdose, sometimes die. So we really want to make sure that any of those type of things are paired with the evidence-based treatment that we know works. We also know that some of these programs have been evaluated, again, with research and do not have an evidence base, like kind of more religious programs that require abstinence only, rapid detox programs, aversion therapy, work therapy that's like unpaid, so requiring people to kind of go into like a work program, but they're not getting paid fair wages. Yes, like having a purpose and working is good for people, but it should be at appropriate wages and that they're consenting to and participating in. And we know abstinence only, especially with opiate use disorder, just has a very, very high risk for overdose and potential death. And then we have outpatient medication for opiate use disorder. There's lots of options with that. We talked about that last time. Methadone programs are very highly regulated at the federal level, often require daily dosing, so generally isn't very available to like rural populations. But we also have buprenorphine, which is like Suboxone, Subutex. And a lot of the low barrier options are tend to be the best options for people that are really struggling with kind of the chaos of ongoing substance use. And then, of course, groups, counseling. Sometimes there's a lot of hoops to jump through depending on what program you're trying to get your medication from. And some people can navigate that and some cannot. So it's good to have, again, options so people can figure out what works best for them. I know some of the questions we have had in the past was, why can't we just kind of lock people up or incarcerate them or force them to get sober? Well, because it doesn't work. It's very, very costly, right, to incarcerate people. Jail is not a treatment option. It really is just kind of forced housing, essentially, barely. We know that incarceration does not reduce crime or drug use in the long run. Costs are unsustainable, and we're still footing the bill for housing, food, transportation, litigating people, and then this continuum of keeping them in this legal system, which makes it very hard then to be gainfully employed and to do like consensual treatment and to engage in other parts of life. And we also know that incarceration disproportionately affects our minority communities. And so we want to be really mindful of, again, having treatment options that work for everybody, that they can engage in, and that we can help them get better, get more functional, become more productive members of society. And so some of the public health solutions that really we want to promote and encourage is expanding affordable treatment, improving access to that treatment and services. This may become a bigger issue in the coming year or two, depending how things go with some of the insurance coverage and people possibly becoming having more uninsured population or less insured population. So this may become a much bigger issue. And a lot of these public health solutions really require a whole lot of collaboration from the entire community, right? So court, legal, housing, mental health, medical health, hospitals, support resources across the board. It is a very complex system to navigate. And so if we can put things in place that help our people that need those services navigate and connect to all the right resources, we have a lot better outcomes. Another part of that is like, even with juveniles, keeping them out of detention centers and really promoting engaging them in treatment, diverting them from the juvenile court system if possible, and finding alternatives to prosecution and incarceration so that we can really promote gaining the skills that they need to become productive adults and functional adults, and help them kind of start off on a better footing as they become adults. So what do we know works? Well, we talked about this last month some, the voluntary medication for opiate use disorder. We know it can reduce mortality by over 50% for people that engage in treatment and take the medications as prescribed. It also improves quality of life. It helps people become more functional. It helps take them out of that whole cascade of kind of chaotic life circumstances that contribute sometimes to ongoing substance use. We know harm reduction and promoting safety really creates opportunities for people to connect with resources, potential for change, right? Possible ways to engage in treatment, while also reducing the associated risks of ongoing substance use, which is an individual risk and negative outcomes, but also impacts our entire communities. So if we help keep our population healthier, right, there's better outcomes for everybody. So we really want to prioritize increasing low barrier access to the voluntary, evidence-based, available, and appealing substance use care and support. We really want to find ways to address barriers that exist for people engaging in those supports. And we know that historically and in other areas, substance use treatment is the most effective if it is available on demand. So kind of think of like, you know, a cath lab or something like that for any kind of medical emergency that you have. You can get in right away. If there's an urgency, you get the treatment. They kind of roll out all the stops, take care of you, and it's all kind of very smooth. Less so with substance use treatment. You have to find a clinic, you have to schedule an intake, you have to, you know, jump through whatever hoops they might have. And then you have to hope that your insurance is going to pay for it, for whatever the recommended treatment is, and continue to pay for it and not cap your medications at a certain level or limit the amount of visits that you can have. So there's lots of room for improvement and progress. So what are some of the things that we are seeing in Spokane right now that are working? Some of the hospitals are working on medication starting in the hospitals, especially for people that are admitted or come through the ER post-overdose. They can start medication in hospital, and then we are working on smoothing the process to transition them to the community for ongoing care. So instead of leaving it up to the patient to try to call and find somewhere that accepts their insurance and can get them in and will be able to maintain their medications, we're trying to make those connections before they leave the hospital. So they have a follow-up appointment in hand, know where to go, know that everything's going to work as smoothly as possible, hopefully, and really kind of keep them on those medications that we know that can save their life. We're doing more with medication for opiate use disorder in juvenile detention, trying to get some of those adolescents that have either been on medications before, on it and stable on it while they are in the detention center, and again, transitioning them to outpatient care more seamlessly, making sure those appointments are set, everybody's kind of on board, dosing is stable, and helping them work on then gaining more positive coping skills and addressing some of the other risk factors and issues that have contributed to maybe whatever they ended up in juvenile detention for. And then really promoting some of our community programs that have low barrier medication access, promoting safety with our high-risk population, harm reduction, STI, like sexually transmitted infection testing and treatment, with more outreach from the programs that exist to go to the people that need it, instead of just hoping they show up for a scheduled appointment when they don't have transportation or housing or phones or a lot of the things that make it very hard to do that. Having more mobile resources as far as the treatment system goes to meet people where they're at, and really building these kind of coalitions between different programs and companies to work towards our community and help our people that need the help. Another local kind of really neat effort that's going on is a student-run harm reduction kind of clinic. The WSU medical residents have been running this and have been doing a phenomenal job, and have partnered with CHAZ and SRHD, and you can see kind of all the people that have been participating in this to provide harm reduction services to people, and now integrating more other supports. So low barrier medication for opiate use disorder as a walk-in, STI testing and treatment, food, other resources, clothing, and then we're working on figuring out some of the other challenges that these folks are often experiencing, like not having IDs, housing, phone, transportation, all those things. And they are doing a wonderful job of making sure everyone has access to naloxone, training on naloxone, lots of overdose reversals, and getting people into treatment when they're ready. And then this is just kind of a recap on that continuum of care and connection of care. It is really important to have prevention efforts, right, and start early and young with a lot of those prevention efforts, but also make sure people know how to get treatment, access treatment, where to access treatment, and what that treatment looks like, and know what is evidence-based, and not that, you know, like going to AA or NA is a really great intervention, a great way to kind of build community, but there's also medication that really works for this. People don't have to struggle and just kind of white knuckle it and try to stay sober. There are treatment programs that are very, very effective. We know the low barrier care is super important. There's treatments for stimulant use disorder that are becoming more and more available, especially like contingency management. And then evidence-based counseling, social supports, making sure naloxone is available, easily available to anybody who wants it. I always encourage people to have it in their first aid kit. Like, everybody should have naloxone. It is something that you should just have and carry, because it's not going to hurt anybody, and you can save somebody's life with it. Also more with the harm reduction, promoting safety for the community, access to medical care, housing, employment, legal help, you know, kind of all the things that help people be functional and productive. We would like to also advocate, I know the city's been working a lot towards kind of figuring out a navigation center and getting people connected with care. So having peers to help navigate that process, it is a very complex system. There are a lot of silos. And again, depending on your insurance, depending on your coverage, really depends what services and resources you can access. So continuing to work on things like that, building more community and helping the folks in our community that really need more resources so that they can be successful because it is very hard to show up for things when you don't have a phone, don't have housing, don't have transportation, and aren't sure how you're going to access those things. We want to promote education for people, reducing stigma about substance use issues, and also kind of promote having a marketing campaign so people know how to access the resources or the navigation center once it's up and running, and make sure that the people that need it can get to it and know how to access it. There's going to be a new telephone buprenorphine hotline. It's already live on the western side of the state. It's supposed to be coming this side of the state. The challenge with that is going to be access to a pharmacy this 24 hours. I think we have one here. But again, if you don't have transportation, that's going to be problematic for people trying to get on buprenorphine. But being able to utilize some of those resources that are going to be available statewide, and then making sure we have the infrastructure to sustain them and make them available to the people that need them. And then just a couple things, just kind of to reiterate that this kind of mentality of you have to be off of everything or you have to be sober and completely abstinent on everything, including medication, to be sober and to be considered sober is killing our population. Like medication, we know medication for opiate use disorder is effective, and being on medication is not using substances. Like that is a treatment. And so providing more education and helping people understand that medication is life-saving and is really, really effective and can last as long as it needs to, right? People can be on it for decades if they need to. Some people stay on it a couple of years and then decide to taper off. But it needs to be driven by the individual that is experiencing like their own life and stressors and challenges and navigating all of that and knows themselves best. And they would do that with their healthcare provider. And we want to promote having more of these resources that we know work available in the community, more harm reduction, safety promotion for the community, especially for our high-risk community and population.
So Chair, could I ask her a quick question? Because I know we want to have some Q&A.
Yep.
So first of all, your first data point, I'm sorry, are we almost done before I jump in because I was ready to go?
Yep, nope. This is like pretty
They have-
much the last slide.
Yeah,
So
they have like one more
yeah.
slide.
Okay,
You
all
wanna
right.
just wait?
Okay, finish, yeah? Okay. So this is just kind of a continuation of what we're discussing about creating strategies to improve the connections and care and services for our population, for all the entities in our community that are trying to provide services, because siloed care is problematic because we don't all have a system that we're all plugged into to communicate with each other. We don't have information on patients that often are sharing or needing resources from multiple entities. So being able to kind of bridge all those gaps, help promote navigating that fairly seamlessly for the people that need it and for the community providers that are trying to provide it. And then making sure that our providers, our clinics, our resources also have good education on what works, what's evidence-based, recommending appropriate interventions, and then helping promote safety across our population and communities. And then just, at the bottom, some of the, again, just different programs that we know do not have measurable or research evidence-based effectiveness. So promoting ways to work around those things that we know create barriers. And there are there is a medication-assisted treatment locator website for people to be able to find programs that offer like buprenorphine, methadone. There are resources available that are updated quarterly. We have low barrier options here in town. It is a matter of getting connected with the right services, making sure you have insurance that will approve treatment options. And then we have some contact information for our team if you guys have other questions. And we're going to also take questions right now, and then we can also provide some feedback and hopefully information back if you guys have questions.
All right, we'll still do this round robin style.
So Mike,
Council President.
your first data point about young people under the age of 18, 9 out of 10 start with substance abuse. We hear very little about resources for under the age of 18. In fact, I think I maybe only heard of one. So could you just speak to those resources or what's available for under the age of 18?
I can. So there is not a lot of resources. Some of that is because most of the FDA approvals and recommendations we have for medications are for 18 and up. Doesn't mean it doesn't work for under 18. It just means the research initially wasn't done with like adolescent populations. There are definitely some limits on which programs are able to work with adolescents for managing opiate use disorder. So knowing, like, again, working to connect those dots depending on what insurance they have, what coverage they have for where they can go to get on medication. And then a lot of times it also requires some flexibility because sometimes the adolescent population is dependent on other people for a ride and has a lot of other kind of psychosocial stressors and challenges that make it very difficult to maintain stability at times. So kind of working on that whole situation depending on the individual and what they need. Did that answer your question?
You were close. I was just, are there any structured programs that are actually available for under the age of 18? Like, are there 1, 2, 3, 5? That's what I'm just trying to get my head around. We know of many programs for adults, but I do not know of any programs that I can identify that are specifically targeted or supporting people under the age of 18.
So I will say, I know Ideal Options can see adolescents for like medication for opiate use disorder dependent on their insurance. Bloom Psychiatry will see them, again, dependent on making sure they are credentialed with whatever insurance they have. There are some inpatient treatment programs on the west side that will work with adolescents, most of the time with co-occurring disorders, so mental health and substance use issues. So they have some inpatient and more kind of residential programs. And we have programs here in town, like Healing Lodge of the Seven Nations has some adolescent programs for their residential and treatment. It really, again, unfortunately, there's not a like, oh, this place will take them, because it is so dependent on what insurance they have and what their insurance allows and covers.
When you could name them off your fingers like that, I knew we didn't have enough, so thank you.
We do not, correct, yes, and it's difficult, I think, to navigate. Mm-hmm.
Other questions? Councilmember Bingham.
Hi there. I have lots of questions. I don't think we have enough time to get through them
Love
today. But quickly, can we go back to the harm reduction slide that sort of went through the different programs? Right
This one?
there. Yeah.
Okay.
So in your opinion, what are the things that the city or the county should be allowing / providing in that group?
I mean, ideally, all of it.
Okay. And so then with all of those services being provided, in your mind, what is the cost that should be borne by the taxpayer to ensure that all of these services are available for folks?
Well, that will also be dependent on a lot of factors. So like medication-assisted treatment should be covered by insurance for the most part, depending which insurance they have, unless they're completely uninsured. Then that creates some different challenges across the board for treatment of a realm of things. Naloxone, we have different state-run programs to allow naloxone availability, disbursement. There's also a state active prescription authorizing anybody to get naloxone from any pharmacy in the state. It is covered under most insurances. Sometimes there's a copay, sometimes there's not. But so a lot of these things, the cost can kind of be absorbed or managed through alternate avenues, but also it's part of like keeping our communities safe, right? So,
So for the parts that aren't covered by insurance, what portion of that, like the supervised consumption signs, the syringe access, syringe disposal, those, what portion of that, maybe we can just do a percentage, what portion of that should be funded by the taxpayer if it's not covered by private entities?
I mean, I think it really comes down to creating a healthier community. And I understand where you're going, Councilman, but at the end of the day, right now, this issue has become so politicized. Public health has been politicized. I know that all too well, as you do as well. So I think the reality is that if we want a safer community, there are things that the taxpayers are going to have to bear at some level to create that level of safety. So some of these things are sort of idealistic. I mean, we are not going to see supervised consumption services in Spokane, in Washington State for probably quite some time. But as Kayla has said, making naloxone universally available, arguably one of the reasons why we've seen a decrease in overdoses nationwide is because of blanketing the communities with naloxone right on. And I think if we could create a community-wide program that begins with prevention, getting into schools, working with young people, having them understand the harms associated with substance use, and all substances. Back in my day, we did not think necessarily of cannabis as a gateway drug. I do think of it now as a gateway drug, pure and simple. So if we can educate young people to know this is the potential course you may go if you go this direction, let's rein them in. And if we could create, as I said, a community-wide program. So again, I think that at the end of the day, we all have to bear some of the cost for those who are far along this path so that we can create a safer, healthier community.
And I,
Yeah, I'll let you ask one more question, then we'll rotate. So you can
Okay.
finish one more.
So, again, too many questions to be ahead here, I guess, before I get to the question. I do appreciate you coming in here, 9 out of 10. Starting before 18, I have questions on how and who, but I'll ask those at another time. That would be a time where potentially we could get together and sit down and chat, because I agree prevention is a big deal. My friend, Councilmember Cathcart, has long been advocating on this council for us spending our opioid dollars on getting into prevention programs and getting into schools, something that I've long supported. And I appreciate all of that. The question for me does come back to this. You said some costs would have to be borne by the taxpayer because it's a public health situation. And I'm not trying to make a statement here on that. I'm just asking the question, what is the number that the taxpayer should bear?
Yeah, I mean, again, that would be kind of having me reach up into the ether and pull out a percentage without necessarily having any facts or any kind of data to make that statement. So again, I think that rhetorically, I would ask you, are there other public health issues that we ask the taxpayers to bear for the general benefit of the entire community?
Councilmember Klitsky.
Oops, sorry. Thank you. I have kind of a two-sided question. So I'm hearing a lot from constituents about young folks, like Council President has 24 and under, like young adults and minors. What are the options for parents right now? How long, if they convince their child to go into treatment, how long do they typically wait? And is there an involuntary option, and does it work for young people? I've heard that it's not very effective for adults, but is it for young people? Because people want that. Parents want to be able to.
So that's kind of a loaded question.
It is, and I'm sorry,
so
but that's the
age
conversation.
of consent in Washington is 13 and 15, kind of, depending. That includes for substance use disorders. So adolescents get to decide if their parents are involved at all in any kind of treatment or information or what they want to, I guess, participate in. We do not have any kind of involuntary treatment, again, because age of consent is younger, so the parents can't, parents can tell their kid you're going, but like we can't force people to take meds. We can't force them into treatment. And so we really kind of, again, need to work with people on helping find solutions that work for them, including our adolescents, because nobody likes to be told what to do, right? Especially adolescents, but really all of us. And it really helps to have options and kind of figure out what's going to work for you, your family situation, what you want to work on. Sometimes that is like working with the juvenile detention center. Unfortunately, once kids are already in the system, once they've been there and are able to go through detox and can consider what kind of treatment they want to try, then we can try to connect all those dots for them if that's something that they're willing to continue once they leave and something that their support system also can help coordinate and promote. But there are definitely a lot of challenges with the adolescent population.
So the waiting periods, do you know?
For medication or for like inpatient or?
Inpatient or medication or both?
So it will depend on what their insurance is, so what options they have available. Inpatient, a lot of times, is just calling and finding out if they have a bed and coordinating to be able to get in that bed, but the adolescent has to consent to it. Like it's not, we can't detain people for substance use. And then there's an added layer of like transportation to get people to the other side of the state or wherever treatment ends up being. For medication, a lot of times they can be seen within the week, depending where they're trying to get in. It just kind of depends on what insurance they have, what they're asking for treatment, and what they're willing to engage in, and then they have to show up, which is the other part of that.
Councilmember Cathcart.
Yeah, thank you. So I hear what you're saying with regards to educating the youth and making sure that they understand that, they should be avoiding these substances from the start. But I think we're challenged in that we have messaging coming out of the state that's not telling them that at all. In fact, it's actually encouraging more use when they say, don't worry about it, just do it with a friend, just in case you overdose. And I think that that message is probably one of the most harmful messages that we could be sending. And it's frankly frightening to me to think that we have kids who are listening to this that says, wow, it's probably fine. I just need to do it with a friend. It's absurd. I really do believe that's absurd. I know you didn't make those paid TV ads, but I just want to point out the difference in what is actually coming out of the messaging versus what I'm hearing from you. Because I agree, we should be telling them that it is awful, horrible, and any use, frankly, any contact with it could be deadly. And that's not the message that's being sent. So that's very frustrating to me. But I want to follow up on one thing. My perception, and please correct me if I misperceived how you're presenting this information, is that in a lot of ways, what we should be doing, and I feel like you're suggesting this as policymakers, but perhaps you're just coming at it from a more of a scientific perspective, I suppose, but that we should be allowing for people's individual personal desires to decide how they're going to address their drug use. And so I guess my question is, to what end? You know, we have community court that, in theory, is supposed to be telling you that unless you stop these certain activities, such as drug use, you're going to go into a cell. But if a cell is somehow bad and criminalizing and all that, then should we just simply not have programs like that? Should we not even arrest individuals at the front if a jail cell is so bad? I've heard from a lot of individuals that their life changed because they were forced to be away from certain substances. And so I just trying to understand, to what end? And I think as policymakers, of course, we take all the advice, we take all the information, and we have to decide how is that going to be applied community-wide, statewide, nationally, right? And not always because of one individual or a group of individuals do we make policies. We obviously want to think about everybody, but that's not necessarily how policies are made. And so we're trying to think about what is good for the entire community. So I'm just curious, how do we address these sorts of issues?
I think having options that are accessible to people that need to access the treatment services, making sure those options reach the people that need them. Sometimes, so you guys, I'm sure all know this, but I mean, our country has the highest incarceration rates of the entire world, not associated with better outcomes in general. Being in a cell doesn't provide treatment. It doesn't improve coping skills. It doesn't provide resources. It doesn't provide stabilization.
I'm going to disagree because I think that it's how the jail is set up, of course, because you can have programming, you can have educational options, you can have drug treatment options. And if you're an effective jail, you're preventing those substances from entering and leaking through the building there. So I'm going to disagree, and I think if people are assigned, a sentence of a day and they're back out on the street, of course they're not going to get any help from that. But if it's 3 months, 6 months, a year, and they're accessing those treatment options and educational options, bettering themselves, bettering their lives, bettering these other aspects that they need to work on, is that not somehow better than just being on the street, given a free glass pipe to do more drugs from a community group?
I am not a big advocate for incarceration improving much, honestly. I mean, I think there's a place for it. But we all are humans, right? And people deal with different stressors and challenges different ways. Some people deal with them more through kind of legal avenues. People with resources can, right? A lot of people with resources also use substances, but they don't have the same consequences from the legal system and from incarceration that people without resources have, especially our minority populations and our high-risk populations. So I don't think incarceration should be the threat for people who don't have resources to bail out or to OR out, who don't have support and connection in the community. We can create a system, we are creating a system that can catch more people, that can provide more support and resources to help them have more stable everything, ideally, whether that be housing, mental health care, medical health care, substance use care. We need to kind of help have more foundational support across the community, not just for people with resources, but for the people without resources, so that they can access services to become more functional and become more stable, I think. And incarceration so far is not connecting people with services necessarily when they're leaving or when they're going in to be able to maintain any kind of gains.
All right, Councilmember Lambden.
Yeah, thanks, Chair Sapone. And thank you, Dr. Lutz and Kayla, for the information. One question and just a piece of feedback that I think would be helpful for us as a council to understand as it relates to incarceration as a potential strategy is any data available on overdose within 90 days of individuals being released from jail. Because we do know that even if folks are stabilized within a jail setting, oftentimes when they return to the streets without those appropriate resources, overdose is very common. So I think that some of that data would be really helpful for us to see. And when you're describing evidence-based practices or programs that work or might not work, I also think that having some tangible programs or examples from other cities potentially would be something that would be really helpful for us to see in the future. And then you touched on a couple of areas, and I'm curious if there's any more, because as a legislative body and within the administration of the city, we've set forth our legislative priorities going into 2026, one of which, and this is something that you mentioned a few times, Kayla, was really ensuring that folks have access to insurance and the ability to pay for these services. So that's something that we have put forth as something of a priority for the city of Spokane, for our constituents. But I'm curious if there's any other areas that as a legislative body or as a city that we could be putting forward, because as you mentioned and council's mentioned, this has become a very politicized topic. And our role as policymakers is to create policies to ensure a safe Spokane for everyone. So if there's suggestions or policies from other municipalities that we should look towards, particularly in the state of Washington, I think that would be helpful as well.
No, thank you, council member. And yeah, what we're going to do, obviously, since this could go on for quite some time, and obviously you've got an agenda, we're going to be putting together a document for you, taking in light of the questions that were asked and some other pointers for you. Again, I'm really pleased that we had the opportunity of bringing this to your attention. And again, we're here for you, and we'll put some materials together for you. And again, look forward to future conversations. So thanks again.
All right. Thanks for being here. Appreciate it and all the work you do in our community.
Thank you.
All right. Next, we'll go to our police chief report with Chief Hall, and then we'll have our fire chief report after that.
Chair, are we going to combine this with the review, or is Chief going to come back for the review?
I touched base with him before this. I think he's going to mention some of it now, but then I think more of our discussion will be later. So like questions and stuff like that.
But the
that you
Chief
might
will
have.
be here for that?
Yeah, you're not leaving, right? For committee?
No.
Oh, wait.
Okay.
Good afternoon, Council President, council members. There we go. I'll go through this fairly quickly. I think there's going to be a couple of different points where we're going to spend a little bit more time. So a lot of this you've seen, and then some other things we'll have greater discussion on, I'm sure. 911 calls continue to track down. Crime check calls continue to track up, and as I explained last week, we would expect that as less folks are calling 911 and they're using 311 to go through crime check, we're going to see an increase there. Officer-initiated calls, once again, when the officers don't have as many calls for service to go to, they're going to find work. Crimes against persons offenses, this is basically our violent crimes. It's a little bit down from the last 2 years and running static to 2022. Assaults, and both simple and aggravated assaults are what generally drive our violent crime numbers, and you can see pretty much the same pattern there as the overall numbers. Domestic violence offenses were pretty static, pretty flat. Once again, this is something that council asked for earlier this year. It just shows what the most prevalent crime classes are in domestic violence offenses. And that's simple assault, violation of court orders, destruction or vandalism of property, aggravated assault, intimidation, the things that you would expect in interpersonal violence. Property crime continues to drop. You've all seen this before, but I just wanted to point out, we kind of blast through this, or at least I do, but if you actually look at the steps that we have to go through to count shootings that occur, both injury and non-injury shootings in our city, it's very labor intensive and somewhat archaic, and we're trying to fix that on the backside by building a data pipeline, and that you will see moving forward, I hope, a faster and more accurate count that won't take hours and hours of staff time. These are the confirmed shootings with victim injury, or what we call skin piercing injuries. We have less victims this year than the past 2 years. However, our overall shooting calls, then this is confirmed shootings without a victim injury, are concerning to us, and they're tracking up. Earlier this year, council, and thank you, approved the purchase of a NIBIN machine. We now have that NIBIN machine. What NIBIN does is able to take 3D pictures of the cartridge casings. And the firing pins used in the firearms, they leave an imprint on the cartridge casings that's very unique, and it's very much like a fingerprint to an individual. That firing pin will leave the same impression on a cartridge casing. Using that technology, we can link different shootings together, where currently we have a backlog of several months to do that through the Washington State Patrol Crime Lab. No fault of their own. They're basically doing the entire eastern side of the state. NIBIN stands for National Integrated Ballistic Information Network. It's managed by the ATF. It's a national network. It automates the ballistic analysis, compares images throughout the region and the United States if we decide to go that route. Right now, we're just going to do it through the region. After it goes through an analysis, the analysis is double-checked by our firearms forensic expert, and then it goes to Wichita is our regional center for an additional verification before it comes back and says, yes, this is a match, so that we know through that process that we have the same gun involved in different incidents. Moving on to arrests. We're still a little bit above 2023, but still a little bit below 2024. And I would submit, as I said last year, that's because crimes or calls for service are going down. We're going to have less arrests. These are the reported offenses, so the arrests that we're seeing the most of. This is both booked and non-custodial or not being booked, and misdemeanor and felony. As you can see, simple assaults, trespass, driving under the influence, drug and narcotic violations, shoplifting still lead the pack as they have in the past. Unlawful camping with contact warning. What this means is there's been a contact with a police officer for this violation, and a warning was given. There was no enforcement. And you can see the green is 2025 and how that begins to spike up after August. I'm going to go back. This is the same slide that we just saw to show that even though the way the home ordinance was crafted is we were unable to enforce in the traditional sense, but the officers did a very good job of pivoting, and they still continued to arrest for other offenses that had nothing to do with the home ordinance for folks who were violating those crimes. And that includes simple assault, trespass, and I've shown this slide before. The vast number of trespassing arrests occur in the downtown core area. Drug and narcotic violations, once again, the vast number of those arrests happen in the downtown core area. So when the officers understand that they have different tools to use, they use them. They pivot, they leverage, and they use them. And there's been some conversation about what enforcement means. So just so that we're all on the same page, enforcement for us is any application of a legal consequence. So enforcement can be a criminal citation. It can be an arrest with a booking, so that's going to be custodial. An arrest with a citation and a release, that's non-custodial. So just to be clear, citations are arrests, criminal citations. This is traffic citations, continue to go up thanks to the re-centralization of our traffic unit. Serious collisions, and you can see there are a couple of hot spots, but generally speaking, they're on the major arterials, and speed is always going to be a factor. Serious collisions, once again, over the 4-year period, they continue to be static. Fatal collisions, these numbers are small, so you see that difference, but essentially it's pretty much the same. I wanted to run through our staffing analysis real quick. You met Dr. Pietenpol last time. She was able to do essentially a staffing analysis with a small workload analysis. We wanted to do this going into what we call shift bid or markup, where we give the officers the opportunity to bid for new shifts in the coming year. In the past, what we've done is just equally allocated officers to each of the precincts. This time, we wanted to do it based on the data. And so, not to get too deep in the weeds, but we were able to do a staffing analysis to show where we need officers the most. And in some cases, we were overstaffing, and in some cases, we were understaffing. We wanted to right-side that. So what we did is we changed the staffing model completely. We, as of today, have a 3-shift model. Come January, we'll have a 4-shift model. Day shift starts at 6 and graveyard starts at 8, and they'll go until 6:40 for the 24/7 coverage. The 4 precincts will remain, although Northwest and Northeast will be combined for some very large squads for mid-power and graveyard shifts. This is just a visual to give you a better idea of what we're looking at. Same table, except instead of day, I put the times that day shift is on. You can see the overlap, and the overlap is the sort of the secret sauce that makes this work, because at our most busiest times, we have the most officers on throughout the city. And that is the end of my presentation. I think if you haven't noticed, there was a press release that was just announced. I just wanted to say that we have been having conversations, myself, the administration, about the home ordinance. I've had lots of questions about the efficacy of that ordinance, about what the ordinance was attempting to solve, what the outcome was to be. The administration listened, and we continue in some productive conversations about how we move forward to modify the home ordinance so that we can address the issues throughout the city without any geographic or time restrictions to ensure that we are holding primarily the high consumers, chronic offenders that we see downtown accountable, while at the same time leveraging some new resources such as the Cannon Street Shelter or Triage Center to have a place where folks can go, as opposed to what we've been doing is just tell them you can't be here. And then a block away, we tell them again, you can't be here. And then a block away, we tell them again, you can't be here. This gives them a place to go and a place for the officers to direct them to. We're also going to double down on the Crisis Stabilization Center and begin utilizing that in a different manner, in a more effective manner as a resource for the officers to direct folks to go who need the assistance of that facility.
Councilmember Cathcart.
Yeah, I mean, it feels like we're in the midst of that review now. I was going to hold this for later, but I guess I'll just ask it since you brought it up. With that press release, I guess what are the specific changes that are coming? As a council member, I have been told zero, zip, zilch, zero. I have my own ordinance that I'm bringing forward, but I'd like to know what is being proposed.
That it's still in draft form. I haven't seen the latest iteration, but I know that the administration wants to have the input of community members, of business owners, of business organizations as well. So I don't know what the final iteration is going to look like because it's going to take in the input from all of those different components of our community.
Just to follow up then, is tomorrow's press conference then to announce what those changes are or to announce a process however long by which to get feedback from those community members you just talked about? Because there's been no request of council feedback in that process.
Right, and I don't have any insight onto the administration and the council relationships, but what I can say is tomorrow they're going to announce an overarching sort of strategy and what the ordinance is going to look like moving forward. I think it's going to be smaller in scale than the Spokane task force that was announced last week, which is going to look at greater systemic issues within the criminal justice and behavioral health substance use space. This will be more strategic or more tactical in that it'll be focused very much on certain behaviors that, quite frankly, make people feel unsafe, and behaviors that the community has made it very loud and clear they want something done about.
Okay, well, thank you. I know patience has run out. Mine certainly has run out a long time ago, and I just hope that this is more than a blue ribbon commission to talk and feel good, that we're actually going to make substantive, deeply substantive changes to that ordinance.
I think as I mentioned last week at an event you were at, I and my officers are just as frustrated.
Other comments or questions for the chief? Councilmember Vingle.
Are we talking about the the new ordinance that's in the packet?
I don't believe there's a new ordinance in the packet.
Or not an ordinance in here, but
No,
the
just
review
the
of it.
review of it. If you can wait, I think that would be helpful to have that discussion when we get to that item. If you had other things for the chief, and then we can come back to it at that time. And to Councilmember Cathcart's point, I did talk with the mayor and the administration last week, and the idea right now is for council members to be sharing, because this is a committee when we are all able to share input on that too. So that's my intent of having this on the agenda, is for council members to share kind of our concerns about that. But I was going to have it last because I know that we can talk a lot. So that's why I was going to do it last. Okay, Councilmember Bingle.
I would have liked to have talked a little more on harm reduction there for a minute, but my question on this and not the home ordinance, can you go to the new sort of staffing model? I would just like to understand a little bit more on how combining the Northwest and the Northeast, what that's going to look like in practice, how that determination was made, and and how it sort of compares to now.
Yeah, it just allows a bigger squads. So the officers were very vocal in that they weren't able to have the time off that they should have, injuries being what they are, military leave, medical leave. It allows bigger squads for the officers to have the opportunity to have more time off. But it also gives more coverage where we need it based on the calls for service and the workload analysis we did. And what you're looking at right here, those are what you would see at any given time on any given day. Those numbers are actually doubled, so it's 144 officers that we have in patrol right now.
And so instead of them being assigned to, like District 1 or District 3, then they're sort of just going to be covering both. So there's more officers, but they're covering a larger territory.
Yes.
Okay. So more officers for a larger territory, does that mean less officers per acre in essence?
It actually is about the same.
Okay.
But we're given the latitude for the officers to move.
East-west.
In this case, it's going to be District 1, which is by far the highest call generator in the
Right.
city. And that's where we saw the need for more officers because of the higher workload. So it gives them the ability to move their assets over there as calls ebb and flow.
Council President.
Yeah, Chief, I was just going to ask on recruitment and staffing levels. I don't think you spoke to that.
We're doing very well. It looks like this next class, we will probably have 9 going in, depending on our interviews. And then the following class, next quarter, I believe we're looking at least 10. That will put us in a position where we would be fully staffed if we lose nobody in that time period. Or I should say, with budgeted positions. You can certainly expect to see me come before you when that happens to ask for more.
Any other questions, comments? All right. Thank you, Chief, for that update.
Thank you.
Next up, we have our fire chief report, and this will be Chief Oberg's last time coming up to us with an update and report. And I want to thank you for all your service, Chief.
Good afternoon, Council. Thank you. I'm going to start with this, but then I'm going to ask Battalion Chief Forbes to come up and hit some of the data points. We have some of the data points that were specifically requested at the Finance Committee as far as mutual and automatic aid. So I'll start with our staffing report. We did have 1 retirement in September and expect 3 more by the end of the year, 1 more by the end of the day. And our current recruit academy, we are down to 18. We've had 2 resignations since the start. So if you recall, this particular academy will get us to almost flush, but we know that we anticipate retirements and separations going into Q1 and Q2 of 26. So we will still need to have the Recruit Academy 2026. If we don't have any unexpected separations, I do believe that that academy could get us to where we are sitting in that spot with our FTEs that allow us to have a decent sized relief pool that allows us to appropriately manage overtime. Our overtime right now, ending pay period 20, we are at 17% higher than the same time last year. That puts us 105% over the budget spent. When I look at hours, our hours are 23% higher than the same time last year. And again, I keep our FTEs up there just to remind everybody that the hours in the FTE are as much of the story as the dollars are. So our FTEs had gone down from years when we were closer to having our overtime budget better managed. I'm going to ask Chief Forbes to come up and hit on the response metrics.
Thank you, council members. I'll just go through the data stats for us for the last month. Here's our response metrics for comparing the last 2 years over time. You can see there's been a slight increase, but the typical pattern here is 82-ish% or so for medical calls, and then the other 9-10% are fire and other calls. This is broken down by month. As you can see here, we're lagging 1 month in data, and we're gonna do that just so we can get you a better complete data set just by the way our reporting works, and with Public Safety Committee being near the very beginning of the month, so you'll always see just kind of lagging one month. But if we do see something of very odd notice, we'll bring it to you ahead of time if possible. But you can see our call volume's down a little bit for the month of August here, but still that same breakdown of 80%, and then the 9 and 9 for August. Structure fires are down this year, like Chief Williams spoke about last month. The outside is outside of the city boundaries where Spokane Resources went outside of the area, and then the red box there is inside of the city area with City Resources. And then by month, you can see structure fires are down in the city, but a little bit up outside of the city there for August. Brush fires trending back towards normal. But that spike there you see in July was that arsonist that we had running around in some of the park areas. That's where we attribute that spike to. And then I dug in a little bit deeper on the brush fires. These are all brush fires year to date throughout the city from January 1 to current, spread around, but then I did a little analysis on the city-owned property. And you can see the blue dots there reflect where the city-owned property is, and that's most of the kind of park areas and whatnot. And these are brush fires, so actual vegetation fires that the crews determined when they got on scene, not trash can fires, things along those lines, but actual vegetation fires. Let's touch on the auto and mutual aid responses received year to date. So I looked at this from a perspective of receiving them and giving them. So these are responses that were received by our partners. So District 8, District 9, Valley, District 10, District 3, whatnot. And you can see where the concentrations are up north, up in the upper corner there. That's the District 9 relationship there where they come in the city and we also go out. And then down in the lower corner would be Fire District 8, and then a little concentration there to the right where it's the Valley. If we look at, did a little bit of a breakdown on by agency and looked at the total number of responses and how many hours were committed by those resources, and then sort of did a little average of what does it look like per call for time commitment by each of those agencies. And you can see the 15 minutes and 18 seconds is about what each agency gave us overall. Each agency is a little bit different depending upon the types of needs that the type of calls we're going into their area for. If we look at the aid given, here's the aid that the city gave out to those agencies, very similar distribution, north, east, and south end of the city there. It's very interesting. We have almost the exact same time commitment for agency, even though we received more calls within the city. When we go out of the city, oftentimes it'll be for fire calls to support fire needs, so our time commitment might be a little bit longer. But in essence, the city's receiving the same type of aid that we're giving. That's how I would digest these two slides. Let's look at the overdose data. Dispatches are, relatively the same throughout the year. A little bit, they're up from last year this time, but the same month to month to month for the year. And then if we break down the details here, if we look at we'll just start left and go right. This is comparing 24 to 25. The blue line is the number of times we were dispatched on an overdose call, so when Shrek felt like this was an overdose call. And then the red bar, the second line over, is what we determined the overdose to be, or we determined that it was an overdose by our providers. And then the Narcan administration was the next bar over. You can see we had 62 Narcan administrations this month. And the reason why the impression versus the Narcan being different there is a lot of times that Narcan isn't given by us alone. It's police, bystanders, unknown people that were, that might have given the Narcan. And then we had 66 transports to the emergency department, and then 1 deceased on scene in August of 25. By location, you can see this is the same slide you've been seeing for a bit here. Residence is, multifamily, single family, and then the street definition, we're working on getting that, honing in on that being a little more accurate. When we say street, that's not literally in the street. That can be sidewalk, somewhere where our officers determined that this was not inside a residence or not in a business or something along those lines. So you can see that predominantly we're looking at most of the calls being in residences and streets. That's all I have for stats. Any questions for me on those? Thank you.
The last thing, if I can add, as this is my last public safety committee, actually this is my last day period, just want to offer some thanks to you all as council, but honestly, more importantly, I want to thank my staff. So most of my executive staff is here. Between Chief Redding, Chief Nywert, Chief Dahl, and then of course Chief Williams. I have been blessed with a team that comes in every day and works hard to try to do the best for this community, sometimes against some pretty significant obstacles that you all are well aware of. So I have very much appreciated it, very much been an honor.
Chief, we'd like to thank you as well, not for your leadership, but for your trailblazing as being the first female fire chief in the city of Spokane. We're so proud of that, but your leadership as well. And for that, I'd like to give you an applause.
I think that says it all. Thank you so much, Chief, for all that you've done for our community. Next, we'll go to the next item, which I just lost. But you can, yeah. Thanks. I was like, I just lost the page.
Good afternoon, everybody. Sarah Nuss, Director of Emergency Management. Thanks for having me. I don't know how to follow that. That's a hard one to follow. As you have in front of you, we are updating the ordinance to reflect that the city is its own emergency management organization. This doesn't really change much except for cleaning up the ordinance to match RCW around emergency management. Earlier this year, we drafted and published the first Spokane's Comprehensive Emergency Management Plan for the city. And that plan in and of itself explains how we do emergency management internally and with our external response partners. This plan was developed with all of our regional partners and state partners to clarify whose roles are what, across the 4 areas of emergency management, from planning and preparedness to mitigation, response, and recovery. There is no physical attachment to this. This isn't creating an office of emergency management per se with positions attached to it. It's just clarifying the role of the emergency management director, the role of the mayor, and bringing us into compliance with RCW. Any questions?
Council President.
How does this, but the county is still the overall entity for emergency management, so are we separate under them? Help me with that structure.
Yeah, that's a great question. So after 2023, the city has not signed on to a new interlocal agreement for services with Spokane County Emergency Management. So for 24 forward, we have not been under that. That being said, they're not supporting any of our planning or preparedness or mitigation work. By the way, response goes for emergency management and first response in general. The county will still be a resource for us when it comes to responding and activating an EOC, Emergency Operations Center, or otherwise to manage those incidents in support of first responders. We just don't have a formal agreement for that, for the preparedness and mitigation work.
Councilmember Cathcart.
Just briefly wondering, obviously with that separation from the county, what is the level, I guess, of communication and engagement between our 2 entities? Just obviously an emergency in the city is probably also an emergency in the county and vice versa, maybe not always, but often. And certainly I think, whether it's trying to flee, escape, get away from something happening, there's probably a good argument that county folks will be coming through the city. So what does that level of engagement look like?
Yeah, that's a great question. So right now, when we have something happen that it requires evacuations or emergency notifications and messaging, whether that's on the Code Red tool or the WIA, the wireless emergency alerts, Spokane County Emergency Management is already a lead for that. So they already will take care of that, whether that's an emergency that requires that in the city's jurisdiction or outside the city's jurisdiction. So we have a well set up process that if I need support of emergency management or our police or fire needs support, their incident commander in the field will work through dispatch to activate Spokane County's resources in their emergency management office. So that's a well set up process that will work regardless of interlocal agreements, the way we do it during blue sky operations day to day and during larger emergencies or disasters that might disrupt how we do things day to day. Yeah.
Councilmember Klitze.
This might be a wishful thinking question, but does the fact that we've adopted this and come up to state code and everything, does that help with people's fire insurance at all?
That's a great question. I'll have to look into it. I'm not sure, but I would love to find ways to encourage insurance companies to actually start covering folks here in our state. I hope our legislators at local level and state are also looking at the same thing.
Thank you.
Thanks for your time.
All right, thanks. And then we have a special budget ordinance for Fire Department Recruit School and Shrek cost reimbursement. It looks like we have Matt Boston coming down for that.
Yeah, thank you. So this is a SBO that is allocating the money that was received from Shrek. As you probably all remember, there was 2 OPRs back in June that went through council, OPR 2025-049 or something like that, and 48. This is allocating those dollars out to the back payments of expenses, as well as to the second recruit class in 2025 that we've talked to you about. Just as a caveat, this might get amended a bit because this was netted against the 2025 expenses and revenues when we are actually receiving a separate payment for that. This is just for the expenses and revenue attributable from 2022 to 2024. So there might be some tweaks to this one as it moves through the process. Any questions? Yeah.
Could you just detail $190,000 for communication services? What is communication services?
It's primarily the CAD system and the different combined communication system, the combined communication building, all of those different expenses that come into running that facility.
Hardware, software, not
Yeah.
individuals or anything like that?
No.
Okay.
No.
Anyone else? All right.
Thank you.
Thank you, Matt. So this time, this is the review of the obstruction and unlawful camping ordinance on the agenda. So I don't know, Chief, did you have anything else you wanted to add to that, or is that kind of the main stuff that you mentioned? So the intent of this was really to start, baked into the ordinance was a 90-day review policy. I think that we've been hearing from our community that there's some changes that we can start working on now, that we don't have to wait into that. I think Chief was mentioning that he's seeing some changes that he would like right now too, so I think we can start working on those now and using this as an opportunity from council members to kind of give some suggestions so we can start working towards that, ideally in a collaborative way. But I don't know if you had anything else you wanted to add on to those.
The only thing I wanted to add on is something that I've been looking to do since I've came here 13 months ago, is working with the courts, the municipal court in particular, to explore what we call area restrictions, either as release conditions or conditions of sentencing, so that in small areas where these folks are constantly creating issues or problems, that the judge will order them to, like I said, either as a condition of their release or a condition of their sentencing, that they can no longer inhabit that area. Obviously, there'll be carve-outs if their doctors, their behavioral health, or their treatment centers are there, and for transit in and out of the area. But actually being in the area is something that we also want to explore for some of our chronic acute offenders. The only other thing I'll add, and it ties into the ordinance, but it's not a part of the ordinance, is we have just formalized a white paper that's being circulated amongst our partners right now for a high utilizer treatment list. And this goes to what we've talked about in the past, the 10 dedicated jail beds. Jail is one of our partners. Providence is one of our partners. Consistent Care, Catholic Charities are all a part of this. We have identified through a matrix of criteria the top 10 problem folks are the highest consumers of services, including behavioral health, substance use, medical, police, fire services. And when we come across those folks, we know right now they all have charges. They will be booked in the reserve beds at the jail. We have an agreement with the jail and the jail's behavioral health that Consistent Care can come in and begin engagement immediately. We have an agreement with the judges that they will release these folks at such time as when they've been stabilized. So the goal here is not to warehouse these folks indefinitely in jail. It's to get them to a point where they're stabilized, where they can make an informed decision about their care. And then a warm handoff to a treatment provider through Consistent Care. And that will be operational, I believe, by the end of the month. We were hoping it would be ready to go as of now, but it looks like it'll be by the end of the month as we formalize some MOUs with our partners.
Thanks for sharing that, Councilmember Cathcart.
Yeah, I mean, there's a million things I could ask or go in a direction of. I guess really quick, just because you mentioned it here with the stay out stuff, and I'm a huge advocate of the SOTA that Seattle and other places have implemented. Would it include that in your mind, the drug area specific designation?
I've been having conversations with my counterpart over in Seattle. They're struggling with the soda ordinance as it stands, and that, I mean, I'm too far out to understand exactly what the struggle is. I think there's some misunderstanding or misapplication, both on the law enforcement side, but also on the judicial side. So until they figure out how to make that secret sauce work, I'm kind of just watching to see. But I am open to it. I'm not closed to it at all.
And then on that, what would be in your mind the penalty if somebody is violating this day out? Is it just community court and they go right back to that spot again the next day, or is it some actual penalty on the back end?
I'm a big believer in scaled accountability. So sure, you get caught once, community court. You get caught twice, maybe community court. I mean, these are decisions beyond me. But at some point in time, you know, just doing the same thing over and over is not going to fix the problem. And quite frankly, the problem might not be fixed either by community court or jail, and it might be fixed elsewhere. And that's something else we're looking at as what we can do with the services we have here and the complete lack of services for high acuity populations that are in active crisis or psychosis. It just doesn't exist.
And then just one quick, I was hoping that as a part of this, you know, I know you had announced there was a pilot program on the South Hill to collect data on enforcement and warnings and tracking data. I was hoping we'd get some kind of presentation to see what those numbers look like, what is the data collection process look like. I'm just hoping for more information on that piece.
The slide I put
forward.
up on the UCamp engagements, that's how we're tracking it. There's no enforcement there. And quite frankly, as I think I've said before, with the home ordinance as it's currently written, enforcement is compliance. We ask them to leave, they get up and leave. But the way the ordinance is
Did
written.
anybody accept services? I mean, that to me is fundamentally why, I don't want to speak for anybody, but why this policy was enacted is because suddenly all these folks were going to get access to services and they were going to accept it. Has anybody accepted services? That's really fundamentally what we need to understand.
Not from my officers.
Okay.
Councilmember Klitzky.
So for the sentencing ideas, is that going to have to come before council, or can the courts do that themselves?
I honestly don't know. I would
Okay.
assume the courts can kind of do that themselves because they can do a lot of things at judicial discretion.
Okay, thank you.
Yeah, go ahead.
Okay, I'm trying to take turns. The other question I have, is it simple enough and easy enough for officers to navigate folks now? I know that people seem to not be taking advantage of resources, but I kind of wonder what that looks like when our officers are encountering people. There's such a complicated system of services, and the hours are also, to me, not very impressive. Is there a way that you see that could simplify that for officers? Is there a triage idea out there or other things?
That absolutely is part of the conversation that we're having now with how we're going to modify the ordinance. It is very complicated, and the officers are not going to, you know, go through a Rolodex, for lack of a better term, trying to find the right service provider for this individual. You know, and that's, I'm going to continue to go back to the, you know, what I used to call the third place, and that's that crisis stabilization facility for high acuity patients. That's 24/7, no wrong door. Whatever the issue is, they take them. For the most part, it should be hospital-based because a lot of times they will have medical issues. This model exists in other states. It doesn't currently exist in Washington State, but I think it is definitely the way to go, and I'll just keep pounding that and pounding that. But to your question, we're working on it. We're working on coordination of services. I think the Cannon Street Triage Center will help, and I think a re-emphasizing of the Crisis Stabilization Center, which is not for high acuity and it's voluntary, but I do believe that we've underutilized it, and it's a fantastic facility.
Councilmember Cathcart.
Yeah, you've mentioned the day center a couple of times, and I'm wondering, I'm assuming there's some component to this new ordinance that's going to talk about moving people there, but it's a day center. So at night, are they going to get a pass on camping because we shut that down for overnight, or no?
No, there will be no time restrictions or geographic restrictions with this ordinance.
Okay.
Councilmember Bingle.
But where will they go?
That is the question, and that's the question we've been dealing with for years.
Right. And again, I would say that this doesn't solve that question. And one of the things that's been frustrating is that that question of where will they go is, you know, a frequently used argument against things like Prop 1 or anything like that. And if this still doesn't answer that question, I honestly don't see, you know, it's how is this the solution there? Because I think we all agree that there needs to be a place outside of jail where people can go and get the services that they need. But again, if there's no place there and we're navigating people to the navigation center that's not open, are we then just dropping them in another neighborhood?
Well, I believe the way the model works is there will be caseworkers, there'll be outreach workers at the day center who will try and engage them either for emergency shelter, transitional shelter, or transitional housing. That's the goal. Now, whether those places actually exist is a better question for Don Kinder.
But we're talking about the hours that it's not open. The hours that it's not open, there's no caseworkers there.
Right, but during the day, they should be connecting or doing the best they can to connect these folks so that they will have someplace to go at night.
Okay, so to keep going on this, if I could, so somebody is contacted at night though and it's closed, right? What do we do with them then?
Same thing we do now. They get a site and move on.
Okay. I do have a question for you as well on the stay out areas, which I'm a huge fan of. Would you define maybe a stay out area? And this is more of a rhetorical question, so you don't need to actually answer this one. Would you define a stay out area as something like can't be within 1,000 feet of parks, schools, hospitals, or daycares? Because I think I would. And I think that's what we had before, is that you couldn't be within 1,000 feet of these areas.
I think the way they're being used now, both area restrictions and stay-out areas, is where the individual is causing the issue. Mm-hmm. If there was a vandalism, they broke out a window, if they assaulted a shop owner, then it would be probably street segments, so 500 meters square, where they would be ordered to stay out of.
Any other questions for the chief? Otherwise, okay.
Just data collection. One component of what I'm trying to suggest that we put forward mandates some data collection. And I just would like to understand from your experience, your officer's experience throughout this process, what would be because we have to collect the data. So what's the most effective, efficient way to do that doesn't have them sitting in their car for an extra hour, you know, doing that sort of work?
We're looking at a couple of different things. One is a phone app that we actually, with the old CORE initiative, we had, I thought one of the biggest successes out of that was a phone app that the officers could use to input data in a very short amount of time. One of the biggest issues from a legal standpoint that we're struggling with is we have to have, I mean the police officers doing the work, have to have the legal justification to stop somebody and get their name. Under the current ordinance, if they comply, we have no legal justification to get their name if they don't want to give it to us. And so that's one of the issues with the data collection right now is we don't actually know how many times one person has been given the compliance order because we can't gather their names legally. So having the officer discretion to make that decision to stop under reasonable suspicion is key to this ordinance.
Okay, thank you.
Councilmember Bingle.
And I have one more statement/question in here that you just happen to get caught up in because you're at the microphone there. So the question is, you know, I hear a lot about, you know, collaboration all the time, okay? The current ordinance obviously isn't working. I don't think the 2 council members that represent downtown have been engaged. I'm not sure how many groups that are operating downtown have been engaged. But if we are going to actually be collaborating, my request is, you might not like my opinion. You might not like what I have to say, but I think I have a right to be in those spaces. I think I have a right to be in that room, to be in those conversations, because it primarily affects the people that I represent. And I think it is keeping representation away from the table when people like Councilmember Cathcart and myself don't get to be there. And so as we're bringing ordinances forward, whatever the fix is going to be, I think that it is good for the representatives of that area to have an input and a say, because we're the ones who talk to the stakeholders every day. I know that you do too, and I appreciate that. Captain Reese, all the people who are working there, I appreciate that. But when it comes to council representatives, we're the ones who sit on the DSP, we're the ones who sit on the bid, we're the ones dealing with the residents themselves, and I think we have a right to be at that table as their representatives.
I don't disagree.
All right. And on that point, I think that goes to our collaboration right now as council, but what things are we looking for in an update as council members so that we can all start working towards a solution, the administration can hear from all of us together about what are the solutions, what are the things that we're trying to do in an update. So I don't know if there's people that want to go first, or, I mean, I can jump in too.
Yeah.
All right, Council President.
No, I just want to really be respectful of the people who come to comment on this as well. So we're going to be here all day,
Yeah.
regardless of what the conversation is. So I do want to maybe take that into consideration.
Yeah, I want them to hear I'm sure they're also interested to hear what council members' perspectives are of what we're looking for too. So I think that's why it's on the agenda first. I can share some things I've talked to the administration about that I'm looking for is looking for something that is citywide still, because I'm very concerned that if we're just focusing on one area, it can end up in my district or other districts. And so I still think that we should have something that can be a tool that's used citywide, something that does give officers discretion. Very supportive of that so that you can interact and cite anybody. And very supportive of something that covers the entire right of the way. I think we're seeing gaps that are not covered by the entire right of way by the current obstruction ordinance. So I'm very supportive of a fix that makes sure that officers can engage with everyone on the entire right of way. So Councilmember Beagle.
Yeah, I think I was pushing for citywide the whole time, and that got shut down. So I'm glad that we're looking at citywide, because you're right. I mean, downtown is an important area that we need to protect, right? It is the engine of the city. It's the economic heart of the city. But again, it does go out into other neighborhoods, particularly if we're navigating them into other neighborhoods. There needs to be protections there. So I'm a big fan of citywide. I'm glad that others on the dais are now here with us on that. When it comes to where it can be implemented, those are things that we were saying as the home ordinance was coming forward. I'm glad that we've changed our mind on that. And I think that as we're going forward with this, the other things that we need to understand, and I want to see this reflected in our policy, is that what we are describing is behavior, because it has nothing to do with your housing status whatsoever. Dropping trowel at a meeting and relieving yourself on a sidewalk, that's a behavior that is unacceptable whether you have a house or not, okay? Those are the things that needs to be really, we need to be cementing that as it's coming forward, because a lot of people want to say, well, you're targeting the homeless. No, we are targeting specific behaviors that we as a community are determining this is unacceptable no matter who you are. So just that principle in general as we're going forward, these things are unacceptable, and if you're committing them, we want to navigate you, but if you reject the navigation, it is unacceptable to do that, and there is a consequence for that. Those are the things that need to be implemented.
Councilmember Klitsky.
Thanks. I also agree that things should be citywide. I live in West Central, and whenever there's a huge crackdown downtown, I see a lot of uptick in my neighborhood, especially along the Centennial Trail. And it affects our neighbors and increases our fire risk actually considerably when that happens. As far as the obstruction issue, I think that maybe this isn't having the intended effect that we wanted. I know that multiple times when I've had to call the police about obstruction in front of the ballet studio that my daughter attends, they won't address the person unless they're completely all the way across the sidewalk, which I don't think little girls and their parents should have to tiptoe around someone who is incapacitated and not quite overdosing, but also moving in unpredictable ways where you don't know if you approach that person whether they can see you or respond to you, or they're going to hit you. And so, I mean, we have a lot of children in the evenings downtown, and I think this also brings up the issues of the hours of the places where we're triaging people, because the evenings are when people are doing their rock climbing classes, their ballet classes, their other dance classes, yoga, all of those different kinds of services, including dining. And we forget that this isn't just adults having their aesthetics and clutching their pearls, it's also children walking by. I've been dealing with this for 9 years. I feel like I know how to navigate it with my child, and I feel like hopefully my child will never become addicted because she has seen a lot and she knows what the consequences are. But that doesn't mean that's the way that we all want to teach our kids about these issues. So I am still hoping to see us do a little bit more of a complete job with obstruction, and would love to hear the language that would actually work and give the discretion and allow you to ask names. Because we really do need to be getting those names to track the data. It's not about criminalizing things, but there are folks out there that are not just out there because they're vulnerable. They're out there because of repeated choices, and our children really shouldn't be bearing the brunt of that every evening.
I'm going to let other people go first. Sure. I don't know. Councilmember Lambton.
Yeah, I think the one thing I would like to see really baked into any updates is honing in on some of the data collection pieces, hearing that we're unable to collect those names unless there's a lawful reasoning for getting that information from individuals is concerning to me. I think the idea of having those 10 beds could be challenging to actually really capture those frequent flyers if we can't collect those names. So I'd really like to see some of those changes happening. And not only for that reason, to make sure that we have really sound policy, but also to ensure that any money that we're pouring into any of these new programs, whether it's the Daytime Navigation Center, our outreach teams that'll be going out with police too, to understand how our funding is impacting the community. And then the other piece, and I was excited to hear that there are plans to engage business owners, is really understanding how there's an effective mechanism for businesses to report individuals who are regularly inhabiting right outside on the right-of-way by their properties, and ensuring that there is some accountability. And again, going back to the data metrics, ensuring that we're tracking those folks that are regularly going to businesses.
Councilmember Cathcart.
Yeah, and I'm going to do my best to try to get what I've put together out tomorrow. Just obviously, there's a lot of factors trying to get that done. But for me, what I want to see is I want us to take the entirety of Article 6 under 1202 seriously. That's what I think we need to do. So not just the obstruction, but the entirety of that section. I think there are a number of state laws that we could actually be utilizing to a much higher degree that would reinforce our so-called commitment to the environment, to preventing illegal burns, to a whole lot of things that I don't believe we have actually emphasized to the point that we should. Within the obstruction, completely agree. We need to redefine what was changed in terms of how we define obstruction or sit lie, as you will, if you will, to understand that that is not just the entirety of a sidewalk or right-of-way, but any portion therein. And also, we need real enforcement mechanisms, whether that's at the discretion of the officers entirely, or some other more mandatory, in particular as it escalates. I think that we need to look at those sorts of things. But the entirety of that should be considered, I think, one law in reality, because they all really do affect each other. And I will just say, too, obviously there's a lot of challenges that you have faced in enforcing the existing ordinance. And we are seeing more and more people downtown causing issues in some cases, camping and others, than we've probably ever seen before. And yet, despite that, I will just say, I am seeing more people in the Shiloh Hills neighborhood where I live camping illegally and getting into no good than I have ever seen before. So I don't think it's necessarily just when we enforce, we see an increase. We are just seeing a flat out increase. I mean, this is the worst I have ever seen this community when it comes to these types of issues. And I think that anything we can do that sends a clear message that these behaviors are not going to be tolerated in this community is what we need to do. Now, there's a lot of, I am open to a myriad of options. I'm open to a lot of compromise to get us somewhere that will actually make some substantive changes. But we can't just fiddle. We can't fiddle. Fiddling is not going to accomplish anything. And the folks on the street understand that when and if we're taking something seriously, and we need to make sure that they understand that.
Councilmember Bingle, then Council President.
Yeah, and I would say this is why collaboration is necessary, because I think some council members are understanding some things that we learned a long time ago. And those were all things that we said previously, and they were ignored, and now we're here, and I'm glad that we're here. But when we're talking about needed language, Proposition 1 actually came from, I think, because it looks word for word, like the ordinance that Councilmember Cathcart and I were working with the previous administration about when it came to schools, parks, daycares, healthcare centers, that sort of thing. And so there was a lot of work that was done in there, and I wouldn't consider it lazy, to re-implement Prop 1. As a matter of fact, I think that's going back to the language that was given to us by former Chief Meidel. This is before you new police leadership. But there was a lot of police input that happened on that, on what are the things that we can do and how can we do it legally. And so when we're talking about needed language, we've had the needed language for some time. And I think it's just time for us to re-implement the language that we've already got.
Council President and Councilmember Dillon online.
Thank you. Just a couple of things. First of all, under Prop 1, back in December of 2023, and we could play the video clip at some time where Chief Meidel said they were not going to be able to enforce Prop 1 the way they wanted, the way the community expected. Those calls would come in, they would go in the queue, they'd be responded to on the sense of urgency that was out there. So we'll put that available in the link for you all to see, but I just want to level set that. Also on behaviors, one I started working on when I first came on council with a lot of pushback from the downtown businesses is, we've talked about bathrooms. It's a public health issue. We know that there is nowhere to go to the bathroom by the time the mall locks up at 8 o'clock until I think the library opens at 10, which is why you see a large number of people there. Outside the transition center, those things have to be taken into considerations when we're talking about behaviors. Not to be in the ordinance, but those are some things we cannot leave out if we're looking for different outcomes and behaviors of the people who are out on the streets.
Councilmember Dillon.
Thank you. Yeah, I'll just echo that about the former chief's, comments, and also, with Prop 1. I mean, I think part of the hangups on this ordinance and the challenges and what needs clarification specific to encampments is the notice on days. And Prop 1 did have, a 3-day notice with a gradient to a 5-day notice. So that was in that current code. And this is really, I think, the part of the challenge in how we address that. I really do like coming up with, new language that clarifies, that does have, I think, a better, graduated system for different kinds of violations. And also, one thing the home ordinance did do, I think, was had greater clarity around when a notice was not required, and that was open drug use, that was trespassing, and those are, again, very behavioral and conduct focused. I mean, I sort of see two different things kind of running together. One that clarifies the encampment ordinance, gets to the bigger change that Councilmember Cathcart is talking about with right-of-way obstruction and focusing on the welfare of everyone, our businesses, pedestrians, individuals experiencing homelessness themselves, and trying to come up with, I think, a stronger policy. I'm all on board with that. But then also, I think, how do we kind of strengthen and clarify some more of the conduct based, parts of the municipal code? I mean, I'm also hearing from a lot of folks that, it's not as much of the homelessness that we're concerned about. It's open drug use. And how do we, I think, as a city, come up with some better understanding around enforcement, what that looks like as a priority. Those are the things that are going to have to move in tandem with this.
Councilmember Cathcart.
Yeah, just really quick. So, Council President's right. I mean, that was said by Chief Meidel. However, I think at the same time, or around the same time, myself, Councilmember Bingle, probably many others in this room, in fact, recognize publicly that would be the case. And the fact is, it was a tool. It was always presented as a tool. Sit-lie is a tool. Everything's a tool. I mean, we had sit-lie for a long time, and Chief, we did not enforce it. To your point, you brought that up to us. I mean, these are tools that you choose to use. However, what Prop 1 did was it forced us to prioritize and to focus in on certain areas, particularly where there's kids' activities, and for good reason. And so even with a new ordinance that's citywide, that allows officer discretion to enforce, that is a tool. I could sit here and say, well, there's no way we're going to be able to enforce all those camping issues with this citywide policy and officer discretion. It's a tool, and that fundamentally is the point of all this. And so I think that that's a really important distinction for people to understand. No matter what we pass, there will be instances that do not get enforced, whether rightly, wrongly, whether I think it should or shouldn't. That's just the way it's going to be. And I think that that's something that the public, many in the public probably understand, maybe some don't, but that's something that as leaders we should be helping folks to realize that that's the case. One quick thing, obviously, Chief, you were at the Safety on Second Town Hall. Just one piece, and this isn't something that I would suggest per se goes in this ordinance, but I do think that we need to look at some of the activities that were going on around on Second, around where we did that town hall at the Tuxedo Gallery, honestly, as sex crimes. I mean, literally, that's what it is. And they've identified a number of trafficking instances and things like that. And so just in the big picture, how do we focus in on those sorts of things and really make it clear again that those are not all activities that are acceptable in this community. But even from the trafficking side, there's got to be some ways that a business owner who is seeing something can say something, right? By the time they would call an officer, they'd be gone, right? And it just it's very challenging, but there's got to be some mechanism to really alert folks to those sorts of things that are happening, because it's truly scary for our community to be dealing with that stuff.
Councilmember Klitsky.
Thank you for standing here through all of this, by the way. I have a question I think is for you, and it doesn't need to be answered right now, but just I need help with language from folks. When we passed the homeowner ordinance, I thought that our obstruction language and our camping language was giving officers discretion. That's why we took out the day notice idea. I'm certainly not interested in going back to Prop 1, which had the 3 to 5 day notice. What we were trying to do there is have officer discretion, but the feedback we have received is that that's not what that did. So before we move forward with this, I need to know whether you're more interested in some kind of more structured escalator of how many times you've talked to someone, or if you're interested in total discretion, and if you're interested in total discretion, what that looks like. When I spoke with Officer Reese, it sounded like he was interested in discretion. I feel like I've already tried and failed to do that, and I don't want to get stuck in sunk cost fallacies and reviving old ordinances. I want to do something new that actually works. So whatever you all say, we need to find out, is this what we really think is giving you discretion?
I appreciate that, and we spent some time trying to determine the legislative intent of this body going through with city legal. The issue wasn't with discretion, the issue was with the compliance language. Once they complied with the officer's request, which was required in the ordinance, then we're done. Compliance is the enforcement piece of that ordinance. So once again, I don't think there was any ill intent on the legislative intent with this ordinance, but it just from a legal standpoint, we struggled with it. What we're crafting now will be much more straightforward, less ambiguous, and less necessary for legal interpretation that, quite frankly, our folks struggled with trying to figure out how to implement that ordinance.
The last part of this that I think hasn't been said yet is I think that there's an urgency around this. I think that council is probably unanimous in an urgency of wanting to get something done. And so I guess this would be more on council, but I would be supportive of this as like an emergency ordinance fix so that could be implemented right away without, the month and a half it takes after an ordinance is passed for it to be implemented. So not sure if there's other interest in that.
I'm just curious. I mean, again, I don't know the answer to this. Are we being dictated to tomorrow as to what we're supposed to pass? Is this a broader input thing that we need to listen to? I have no idea. There's been zero communication, so it's hard for me to even agree to with what you're saying.
No. I think right now this is the conversation, is the input of like, if we're trying, I'm going to try to summarize some things that I think that there was a lot of consensus on. I was hearing urgency. I was hearing something that applies across the city. I was hearing something that applies and gives discretion for officers so that they're able to engage, and something with escalators and more backbone. I think there's an interest of people being able to execute it. So I think, we don't have a council meeting next week, but it's something that we can talk in between meetings and hopefully work towards something else that could be passed.
I think I can certainly see council doing an emergency if we come together on what is we're trying to accomplish with this. That would be input from us and the community, and certainly from the administration, i.e. Chief Hall, as to what he feels his officers can implement. I don't want to do an emergency and we're back here in a short period of time and we still have not been effective. So whatever comes before us that we can agree on, I could certainly support that.
Councilmember Klitsky.
I just want to share my opinion about giving input to the administration. I give it early and often, unsolicited, like whenever I get a chance. Sometimes folks receive it well. Sometimes folks have made comments. Well, you're a full-service council member, aren't you, Councilmember Klitsky? Yes, I am. And so please, let's just keep doing that.
I would also add, I think part of that is saying our process on council side, I don't think that there's a large interest of doing roundtable discussions for 5 months to do something. So I think to your point, Councilmember Cathcart, it's kind of trying to talk about what kind of outreach, what kind of expectation are we? I think that there's more of an interest to get something updated and absolutely wanting to hear from community, and hopefully community members who are here can fill in gaps that we might be missing from this conversation.
Yeah, happy to give my input. It's hard to give input on something you don't know exists. And so how can you give input on something you've never read, you've never seen, you've never heard about? So.
All right. Any other points on this? All right. Thank you, Chief Hall, for that. And I know that other members of the administration are here listening too, and hopefully you'll take back some feedback on that, and we'll have follow-up conversations about that. Next, we'll go to public testimony. So we have 2 minutes for each member to testify on general public safety items that we've talked about. So we have Diane Sutton, Emily Cameron, and Brad Barnett, and then we'll go to Christine Quinn, Wendy Fishburne, Earl Moore, and Jerry Schwab after that. Start with Diane. Oh, okay. So you'll have 2 minutes to testify.
Good afternoon. Obviously not Diane Sutton. I'm here in her behalf as a result of a medical issue that meant that she wasn't able to attend. On behalf of Lost Voices of Fentanyl, LVOF, a national nonprofit representing tens of thousands of families across the United States who have lost loved ones to illicit fentanyl, I write to express our deep concern over Spokane's escalating fentanyl crisis. Spokane is now one of the hardest hit cities in the nation per capita. We recognize and commend community leaders and grieving families, including those who have turned unimaginable loss into advocacy, for raising visibility around this issue. But visibility without bold action will not save lives. Spokane has the power to declare a unified state of emergency, as seen in cities such as Portland and Denver, where fentanyl deaths were cut nearly in half within months by combining compassionate but effective strategies, expanding treatment access, enforcing public health measures, and prioritizing recovery. We urge you to immediately declare fentanyl a public health emergency in Spokane. Implement a comprehensive unified response plan that treats addiction while also addressing public safety. Working alongside local families, businesses, and national partners to ensure Spokane becomes a model of compassion with accountability. The dying must stop. The time for Spokane to act decisively is now. Sincerely, April Babcock, founder and president, Lost Voices of Fentanyl.
Thank you.
Thank you.
Emily, Brad, then Christine.
Hello, council members. Emily Cameron, President and CEO of the Downtown Spokane Partnership. I'm here specifically to talk about the topic that you all just discussed around obstruction and also the panhandling ordinance that was adopted as part of the home package. There would be more businesses here, but this was added late to the agenda on Friday, so I am speaking on behalf of nearly 700 residents who signed a letter to you back in June, asking you to take a closer look at these ordinances and specifically looking at concerns. I want to start by just talking about, since this ordinance took effect in early August, looking specifically at the numbers that the DSP tracks. Our calls to 911 have doubled since August 1st. Our calls to Crime Check have tripled, whilst our own safety contacts have tripled as well. That means we are averaging 30 contacts per day with the public asking us to intervene and support when there are issues. This is because there are people who are loitering, camping, and obstructing our public right-of-ways. And Councilmember Klitsky, I think you hit the nail on the head. The problem is that when this ordinance came before us in June, it was explained that this would prohibit any portion of the public right-of-way of being obstructed. It is happening every single day on every single block. We have businesses who are not able to accept their employees in a safe way, their customers. Downtown is also a neighborhood. And when we think about downtown and we talk about if there's enforcement downtown, what does that mean in other neighborhoods? The reality is that today, businesses and residents who are downtown have to face this challenge day in and day out. Their front door is the public right-of-way. Oftentimes in other areas, you have the ability to trespass because there's private property and setbacks. We don't have that in downtown. So I want to conclude by saying reinstitute things like sit and lie, prohibit stopping anytime in the viaducts, clarify confusing interpretations, look at staffing. I think that is something we can't underestimate. We have to have the staff to implement these recommendations. And I want to say, we would love to work with you. We did that moving forward prior, and we want to continue to give you feedback.
Thank you. All right, Brad, Christine, and then Wendy.
Good afternoon, Council. Brad Barnett, Spokane, President, Spokane Business Association. We represent 210 member businesses and almost 13,000 employees, 13,000 voters here in the city of Spokane. I do want to thank you guys for spending the time to look at these issues today, and this is critical, and I think we do all share the same goal. We want to make Spokane a clean and a safe place. But to do this, we've got to acknowledge that we live in a community based on laws and rules. These rules and laws are in place for stability and prosperity. The policies that you guys move forward with this evening and over the coming months really determine the future of Spokane. And this goes back to 2018 when the City Council suspended camping on public property. So as it's already been stated, we need to reinstate that. We need to no longer allow people and be very clear what obstruction is moving forward. We do have the second highest overdose death rate. I know that was questioned earlier. That is based on CDC data comparing similar cities around the United States. We recently had four-term mayor of Boise, Dave Beater, in for our annual dinner. He laid out the plan that worked in Boise, and it would work here. It works in communities every time it's implemented. In other words, you don't allow people to sleep on the sidewalks. You get people into treatment. They're at the point, if they're on fentanyl, they don't have the ability to make that call. So we have to make that call. If we really care about them, if we allow them to continue to be on the streets, they're going to continue to die. And these policies are condemning people to death, and it's condemning our business community to death. Because we've got businesses leaving town left and right. So I would just ask that moving forward, we clarify this and we help out our business community. Thank you.
Thank you. Christine, then Wendy, then Earl.
This ordinance keeps the revolving door spinning. As long as you are funding Catholic charities, Waters Meat, Julie Garcia, and Cat, we're going to have a revolving door. We also have it with Judge Mary Logan in the court. That needs to stop. There are no consequences. That's why we have this. We have complete lawlessness in our city because there are no consequences.
All right, thank you. Wendy, Earl, then Jerry. And is Earl online? Okay.
I'm delighted to hear what I'm hearing, so I'll just start with that. Wendy Fishburne, marriage and family therapist, also the vice president of the East Spokane Business Association. I haven't been down here for a while, because honestly, I was pretty discouraged with what's happened. Shelby, welcome. Glad you're here. Kitty, really appreciate your voice today. Thank you so much. I'll get in here, but I had to say those things at first. I trust in your ability to change course when faced with overwhelming evidence of failed policies. Thank you. The problem on our streets is getting worse. Toxic compassion is when helping harms. The home ordinance is tragically like community court. The good intentions of that program have entirely missed the objective of its design. Similar to Camp Hope, the idea was great, but it led to becoming the largest encampment of squalor, crime, and human suffering in Washington state. And we just gave her another $2 million. Same with Catholic Charities. The intention sounds lovely and promising, but the outcome is obvious to everyone with eyes. So downtown regularly looks like an episode of The Walking Dead. You guys know this. A Good Samaritan was stabbed to death in front of City Hall. Our vacancy rate, 30%. Overdose deaths, breaking numbers. The city morgue. We're feeding the cancer that is metastasizing through our city. So I understand that you're listening to people that tout best practices and lived experiences, but they're also the very same people that are incentivized to profit from bloating this system. Home starts here has actually become harm starts here based on its outcomes and our own eyes. So please listen to your people. The roundtables, we don't need a bloated framework that funnels good money after bad money when frankly, we don't have money. So please be the ones that courageously and independently change course and say harm stops here. The change begins with you. Thanks for rethinking this whole policy. I appreciate it.
Thank you. And I don't see Earl. So last up is Jerry. And don't see Jerry either. All right. We also have our council committee updates. Yeah,
I just
Council
want a
President.
quick comment to the person who, the very first speaker who spoke about declaring a health crisis around fentanyl. That's great. That would have to be declared by the regional health district and our medical officer, Dr. Velasquez. So if you're seeking that, please go to your county commissioners and make that known.
All right, these should be pretty quick. Is there any COPS update? Councilmember Cathcart? COPS, no, I didn't think so. All right, any update about the Regional Health Department?
Yeah, I'll just say we've obviously had a staffing change that has been in the news media as of late. I can't really talk too much about that, but that's happened, and so we've got an interim pair who are leading that agency for the time being. And we are right now in the process of putting together our legislative agenda for the next session, as well as the budget for 2026 at SRHD.
Anything for Councilmember Cathcart for Health District? On the legislative agenda, are you guys talking about opioid use, drug use, and I guess just some issues that might be on the legislative agenda?
Yeah, there's certainly an overlay there. I mean, it's a number of issues. Some of it has been brought forward from staff at SRHD. Some of it's brought forward from state associations that SRHD is a part of. Some of it just input from the policy committee. And so we had a meeting last week. I chair the policy committee right now. It's myself, Dr. Blakowski-May, and Charlie Duranoma. And so we had conversations on that. We'll have a second touch, I think, next week. To finalize that, but then the board will have yet another touch on it too before it's approved. But there's a couple of House bills that I'd suggested we look at. I shared those with Eric as well because I feel that they should equally be important at the city side. But a lot of it is separate from a lot of what the city would be advocating for.
Thanks. Staff updates from Chris Wright.
Thank you. I'll be very quick. First, of course, I continue to coordinate legal opinions and advice on behalf of council, and there have been a few. Second, we're still working on the overhaul of the municipal code. Our vendor expects to have the first input back to us in December, and then it'll be our job at the staff level to review what they've recommended and get back to them with their suggestions. We're also, I'm not really involved in this, but starting on a separate review of the Development Code, Title 17, and I would expect council's going to see a contract request for that coming up shortly. I know you're all thrilled that my public rule ordinance is finally making it through, and we will probably be taking on that action on that, I think, on the 20th, and I'm looking forward to seeing that implemented. So if you have any questions about that, we've revised it quite a bit to make it a little easier for the staff to bring stuff forward and get it underway, and have some changes to the grandfather provisions for existing rules. Finally, also in the category of thrilling things, Jacoby and I, Mr. Byrd and I, have started our initial review of council rules. So if you have any suggestions on things you want to see changed, we'll be happy to incorporate them. And then finally, we never really got back to council. We didn't have a chance to talk about the AWC conference this summer. And I know Ms. Ochiltree and I were going to work on a presentation there. From my standpoint, I think probably the most interesting topics were the open meetings, public records topics. I still would love to see more direction on transitory records and things like that, and social media, but some good discussions there. The other thing was we, of course, had a parliamentary session. And I know there's a sense at times that we're not terribly efficient on parliamentary procedures, but some of the horror stories we heard from other communities about what happens in their meetings, and we are quite orderly and quite civil and quite compliant with both Roberts and our own rules. So that was kind of heartening in a way, disheartening to hear from other communities that struggle with it, but not so much ours. So that's my report.
Questions? Councilmember Cathcart.
Yeah, just wondering, is that all of Title 17 or just portions of it? Do you know?
Last I heard it was all, but I don't know for sure because I'm not really involved in that project.
Okay.
I could follow up on it and find out.
Timeline, is it like in advance of the comp plan adoption next year? Or?
I don't know. I think they were trying to coincide with comp plan.
Okay.
So, but I know they just finished scoring the bid proposals, and I don't know when we're going to see an actual request for a contract.
Okay, thank you.
On the council rules part, this might be more of a question for Council President. Do you think we might have a retreat to talk about some ideas before drafting or discussing those?
Under consideration based on people's availability.
Yeah, Councilmember Cathcart.
I would just say, if at all possible, let's collect a lot of the different thoughts and compile those first, and then we can kind of discuss those at a retreat potentially. I think it just might be easier than brainstorming at a retreat.
I think that could be helpful too. All right. Well, with that, our next Public Safety Committee Community Health Committee meeting will be Monday, November 3rd. This meeting's adjourned. Thanks, everyone.